Thanks all for coming to the first Department of Medicine grand rounds of the 2025 to 2026 academic year. We're super excited to have this in person again, well, hybrid, but really excited to have folks coming in person. I'm Austin Chen. I'm one of the internal medicine chief residents at the Montlake site for kind of this half of the year. You'll probably then sooner or later on meet my co-chief, Hannah Weaver, who will also be intermittently here as well, especially in 2026. But we're really excited for this talk today. I'm actually going to bring up Dr. Keel here, who will introduce our speaker. Dr. Keel is one of our great hematologists at UW and Fred Hutch, and I think many of you know her. So thank you.
So today, as we welcome our Clem Finch visiting professor, we also pause to honor the extraordinary physician scientist and mentor for whom this lectureship is named, Dr. Clem Finch, or simply Clem, as he was known to friends and colleagues. Dr. Finch came to Seattle in the early 1950s as one of the founding professors of medicine at this very institution. He became the first head of the Division of Hematology at UW, building not only a division, but a vision for what academic medicine could be like in the Pacific Northwest. Under his leadership, UW quickly gained a reputation for combining basic science, clinical insight, and rigorous education. Over his career, there we go. Over his career, Clem built a world-renowned iron biology program. Using radio-labeled iron, he pioneered ferrokinetics, mapping iron absorption, storage, and use in red blood cell production. He showed that absorption rises in deficiency, falls in overload, except in hereditary hemochromatosis, and is blocked by inflammation, decades before the discovery of hepcidin, ferroportin, and erythroferrone as the molecular mediators. His work proved that hemochromatosis stems from hyperabsorption of iron and that phlebotomy is an effective treatment. He also collaborated on improved blood storage methods and helped the World Health Organization address nutritional anemia and support iron fortification programs in the developing world. But Clem's impact on UW went far beyond the lab. He also left a legacy of exceptional teaching, shaping generations to think physiologically at the bedside. He co-authored the Red Cell Manual, which became a teaching cornerstone for medical students and residents here. His teaching shaped generations of UW physicians and more than 150 fellows and scientists, many from around the globe. They trained under him, carrying his intellectual rigor into their own careers. And then there was Clem, the person, 6'5", striding across campus, commuting by Vespa, scaling the health sciences building when he forgot his keys, even drying mushrooms in the lab's lyophilizer. He once experimented with working all night, every other night, to gain more time for science, a routine he wisely abandoned a week later. Through it all, Clem Finch embodied the best of UW medicine: intellectual boldness, translational impact, devotion to teaching, and a healthy sense of humor. It is in his honor that we welcome today's visiting professor, Dr. Benjamin Ebert. Dr. Ebert is a physician scientist whose work has reshaped how we think about blood diseases and, more broadly, the links between aging, inflammation, and cardiovascular risk and cancer. He earned his undergraduate degree at Williams College, completed his doctoral training at Oxford, trained in internal medicine and hematology oncology at Mass General and Dana-Farber, and conducted postdoctoral research in cancer genomics with Dr. Todd Golub at the Broad Institute of MIT and Harvard. He now serves as president and CEO of Dana-Farber Cancer Institute, and he's also an elected member of the National Academy of Medicine. Among many contributions, Dr. Ebert's lab defined clonal hematopoiesis, or CHIP, an age-related expansion of blood cell clones carrying mutations associated with myeloid malignancies. Today, he'll speak to us on the origins of cancer. Please join me in welcoming Dr. Ebert.
Thank you, Siobhan. It was an extremely nice introduction. It's so fun being back at University of Washington. I've had so many colleagues here who I've known for many, many years and careers that have intertwined. I've known Siobhan since we were both postdocs, and I've always known she's an amazing scientist, clinician, translational researcher, teacher, mentor. What I hadn't realized until this trip is she probably has the coolest car of any faculty member at the University of Washington, a gorgeous British racing green Porsche. So she's that much more cool than I had even anticipated. So thank you for the introduction, for hosting. And so honored to be linked to Clement Finch. And I grew up very much with red cell biologists as mentors. When I was at Oxford, Sir David Weatherall was the godfather of the institution and a leader in the thalassemia world. As a medical student, I worked with Frank Bunn, who was also a red cell guy. I think injected radioactive iron into himself to track iron kinetics in the pre-IRB days, and so kind of always felt red cell biology was a huge part of the foundation of not only hematology but physician scientist careers. Really a model of combining basic science and clinical medicine. So honored to be here, and I'll talk to you today about how initiating mutations in cells leading to clonal expansions changes a little bit how I think about the initiation of cancer and the very first mutations that occur, and what the implications might be for early detection, early interception of cancer. These are my disclosures, none of which are directly relevant here today. So we know now that we are acquiring somatic mutations every single cell division throughout our lifespan, from the very first cell division to everything after that. Mutations are acquired, somatic mutations are acquired, and you can sequence those cells at the genome-wide level, and every cell would be barcoded with its unique heritage of where that cell came from. And enormously elegant studies can now be done to understand where any individual cell came from developmentally in a human by its collection of somatic mutations. In the brain, you can tell where each neuron came from, often surprising where it originated. You can see clonal expansions in many, many different cell populations. Most of those somatic mutations that occur that barcode those cells are completely neutral physiologically. They don't have any effect on the fitness of the cell. Some probably if of the mutations that do have effect on fitness, probably most of them have a negative fitness, and those cells go away and we don't track them anymore. Occasionally, a cell will have a mutation in an oncogene or tumor suppressor gene that will increase the fitness of the cell, at least under certain circumstances. And those may just track a cell, but if those cells occur in a stem cell, or a cell that is capable of self-renewal or producing a large number of progeny, then you can track how those clones evolve and acquire additional mutations. We know that this, when cells eventually become malignant, that they have to have acquired many different mutations, that when we've sequenced cancer now routinely in clinical practice, look at the genetics of cancer cells, they don't have single mutations, aside from some translocations that drive things like pediatric leukemia or sarcomas that are incredibly powerful, very rare events that drive pediatric malignancies. Most adult cancers, if not virtually all adult cancers, are caused by the sequential acquisition of quite a few mutations. In leukemias, maybe 3 to 6 mutations will drive the cancer, and in solid tumors, often many more. So all cells have these somatic mutations. Some cells gain a fitness advantage, and those early clonal expansions may vastly exceed the number of cells that actually become malignant. In the case of myeloid malignancies, we know they originate in hematopoietic stem cells, or cells with capacity for self-renewal. Those can lead to clonal expansions. One of those cells, of course, may acquire an additional mutation. One of those cells may acquire an additional mutation, leading to a succession of clonal expansions. There's a number of implications. That one is that those initial mutations and initial clonal expansions are much more common than leukemias are. Another is that the bone marrow of somebody who gets leukemia is really complicated genetically. There are cells with the full complement of mutations that led to the leukemia, and there's N-1 mutations, N-2, and down to just the originating mutation. And if somebody has a complete remission from a myeloid malignancy, those initiating mutations may be left behind. They're morphologically completely normal. There's no evidence of blasts, but those initiating mutations may still be there, and that's part of understanding how we understand the depth of remissions, what minimal residual disease really means, and what the risk of recurrence is. So we first got into this trying to understand in normal people, are there clonal expansions? And we did this originally in a large cohort of exome sequencing data from the Broad Institute, where we could look for the known drivers of myeloid malignancies and see if they're present in healthy individuals with no evidence of malignancy. And incredibly talented postdoc in the lab of physician scientists, Sid Jaiswal, led this work and has continued to be a major leader in this field now, an independent investigator at Stanford. And he found, and then many other labs around the same time found, that these mutations in blood cells are incredibly common. And these are mutations that we know occur in leukemia. About 10% of everybody by the age of 70 has one of these clonal expansions. And just based on the percentage of cells that have the mutation or the variant allele fraction, we know that on average in this study, the average size of the clone is 20% of all circulating blood cells. So they're really enormous clones, not tiny little clones with known drivers. They're not the same distribution of mutations that we see in leukemia that's led by DNMT3A, TET2, and ASXL1, which are not necessarily the most common in leukemia, but those are the most common in those initiating mutations. Unlike full-blown malignancies, and these individuals who are healthy individuals who have a clonal expansion, they tend to have one mutation, occasionally more than one. Those may be in separate clones, or maybe the same, or there may be very rare cases where there are multiple mutations and we are detecting an incipient myeloid malignancy just before it presents clinically. One really major difference in how I think about cancer generation now compared to when I was training is if you do the math of the known mutation rate and the number of hematopoietic stem cells, and we understand this much better, I think, than we had in the past, work from Jan, but also work from genome-wide sequencing at the Sanger Center and elsewhere of many individual stem cells. There are, on the order, to use round numbers, about one exonic mutation per stem cell per decade. It seems pretty good that an individual stem cell isn't requiring coding mutations all the time, but on the order of one exonic mutation per decade. And we have roughly about 100,000 hematopoietic stem cells. And if you add those up, we are not just mutating. It is not a rare event to mutate a tumor suppressor or an oncogene. When I trained, I thought that if you did get a tumor suppressor mutation, you got a P53 mutation, that was horrible luck. Maybe there was a mutagen that caused it, and those are the people who go on to get cancer. But in fact, we're all undergoing a genome-wide genetic screen in our bone marrows over the course of our lifetime, and we will mutate every one of our genes over and over. And the only question then, more like a CRISPR screen, is which of those clones actually grow out. But the initiating mutation doesn't require anything beyond the normal mutagenic processes that happen, the mutations that happen just by spontaneous deamination of methylated cytosines is enough to explain the background mutation rate that would mutate every one of our genes repeatedly. And then the question is, what is the selective pressure that allows those cells to grow out? And do those cells acquire additional mutations that allow it to go on to a myeloid malignancy? The other thing that was immediately apparent from studies is that the prevalence of clonal expansion depends entirely on how deeply you sequence. We started with exome sequencing, which was of moderate depth, and so we can detect a variant allele fraction of a few percent or so. Whole genome sequencing is generally a little bit shallower depth just for expense reasons. But the assays that we use every day in the clinic with leukemia patients tend to be targeted panels with deeper depth of sequencing, and we detect smaller clones. And the assays that we're now starting to use in the clinic for minimal residual disease have error-corrected sequencing methodologies that can detect very, very rare clones. And as you use those really sensitive technologies, all of us develop clones. And so it starts to almost cease to lose the meaning of who has a clonal expansion, because we will all develop clonal expansions. We'll all have DNMT3A mutant clones in our blood, but some of them are tiny and may even be transient and don't have any clinical impact. So what leads a cell to actually clonally expand if a small clone is present? The one that we see the most in our clinical practice at a cancer center like the Hutch is patients who have been exposed to chemotherapy or radiation, and that is a massively powerful selective pressure. We can model that very well in the lab. Chemotherapy and radiation induce p53, induce p21, induce apoptosis. That's the biology of how those drugs are efficacious. If a hematopoietic stem cell happens to have a p53 or a p53 regulator like ppm1D, which is a phosphatase that regulates p53, those mutant cells have a massive competitive advantage against the wild type cells that are dying in response to the chemotherapy. So that is a massive selection pressure and helps explain the predominance of p53 mutations in therapy-related leukemia. There are very powerful sex biases in these mutations. It's true actually in cancer broadly. We have a lot of data in this field because we can look at now over 1 million exomes that have been sequenced in various cohorts and know who has CHIP and have their clinical phenotype. And so we've got incredible resolution, but many of these mutations have quite powerful sex bias. Many of them are male biased. The splicing factor mutations are at least 2 to 1 or 3 to 1 more common in males than females. That biology is completely not understood. My loss of Y is obvious. And then DNMT3A mutations are slightly female biased. We've actually been able to recapitulate that in a mouse model where if you expose mice to estrogen, the DNMT3A clones will grow more than when they're not exposed to estrogen and not when exposed to androgens. So there are likely powerful effects, maybe being possibly mediated by the sex hormone receptors, androgen receptor, estrogen receptor, but that's incompletely understood. There is inherited predisposition that leads to stereotyped mutations that occur. So some inherited risk will predispose to particular initiating mutations and then particular progression mutations, just as the initiating mutations change the likelihood of which gene is the second mutation, the third mutation. And smoking in multiple data sets is associated with ASXL1 mutations, and that biology is not understood at all. And this occurrence of clonal mutations that occur in healthy individuals is not limited in any way to the hematopoietic system. Again, we understand it better now in hematopoiesis than any other tissue because of the enormous data sets. And the reason for that, again, is that we are leveraging data that's produced for other reasons, that when huge cohort studies are examined for inherited risk of cardiovascular disease or any other inherited disorder, blood is the predominant DNA that's sequenced, and all of these mutations are essentially, we're biopsying the entire hematopoietic system for the presence of a clone. And so it's an amazing assay for that. In solid tissues, somebody needs to intentionally take a biopsy, take tiny biopsies, figure out how to disaggregate the cells or do whole genome sequencing on individual cells, only a tiny fraction of the organ. And so it's enormously expensive and enormously hard work to get that kind of data. But the technology is improving, and a number of groups have started to do this in solid tissue. And the very first publication of this came from the Sanger Center, where they looked initially at a blepharoplasty sample, a little sliver under the eyelid that was removed for cosmetic reasons in an older individual, sun-exposed skin, and took hundreds of tiny biopsies from that skin, did whole genome sequencing, and found somatic mutations in drivers of non-melanoma skin cancer, including p53 mutations and Notch mutations, FGFR3 and others, and then recapitulated the spatial appearance of that in this cartoon, which I've very visually intuitive, I think, to understand what is actually going on in the skin of these almost complete lawn of clonally expanded cells bearing driver mutations of skin cancer that coat the skin. And in skin and other organs, you can even start to wonder whether having such a high percentage of the cells bearing somatic mutation could start to change the function of the organ, whether the appearance of skin with age, whether the function of skin is changed by having almost all the cells coating the skin be part of tiny clonal expansions. The esophagus, this has been done now in the lung, uterus, almost all organs. The esophagus is particularly scary. It's exposed to mutagens like tobacco and ethanol, but it even in young individuals in their 20s and 30s who have not been exposed to significant smoking or alcohol use, there's already these initial clonal expansions are smaller, but they are startlingly common. And then with age, you can see towards the bottom that even in an individual in the bottom right in their 70s who's a non-smoker, the esophagus is absolutely coated with clonal expansions with major mutations, again, including P53. And in esophageal cancer, that's a horrible mutation, no, any cancer. But in Barrett's esophagus, when there is a P53 mutation, there's a thought that those are the most high-risk individuals, but there's already P53 initiating mutations present in these tiny clonal expansions. That's a different state than a pathologic state where you can see a large lesion and you can look at it under the microscope, you can see dysplasia, like in Barrett's esophagus, but still these initiating mutations are throughout our organs as we age. So having characterized these mutations in hundreds of thousands, over 1 million now, individuals can start to see different types of clonal expansions. There are the myeloid mutations we've talked about, and those become universal with age. And so we needed to think about this, if we're going to think about it clinically, as having some definition, having some cutoff. And we used an initial cutoff of 2%, which is kind of stuck. That was due largely to technical reasons, that's what we could easily detect. But probably the clinically meaningful mutation clones are even bigger with a varying allele fraction of at least 10%. But CHIP is defined, or clonal hematopoiesis of indeterminate potential, as having a varying allele fraction in a driver of myeloid malignancies in at 2% of the at a varying allele fraction of 2%, which is 4% of the cells for a heterozygous mutation. And in those individuals, blood counts are normal. There's also an entity that's been defined as CCUS, clonal cytopenia of undetermined significance, which is the same with various cytopenias. In addition, there are mosaic copy number abnormalities, gains and losses of particular chromosomes that drive clonal expansions. There are mutations in drivers of lymphoid malignancies that can be incredibly powerfully predictive of CLL, particularly when integrated with blood counts. There are the tiny clones that have minimal to no significance. And then there are clonal expansions without a driver. Those could be drivers we have not identified yet, but they could also just be individual hematopoietic stem cells that stochastically have the right epigenetic state to be a little bit more fit than the other hematopoietic stem cells, and can comprise a large fraction of hematopoiesis from an individual hematopoietic stem cell. And that may become even more common with age as a smaller and smaller number of hematopoietic stem cells supply all of hematopoiesis, and in some cases become really oligoclonal hematopoiesis. So one of the most surprising aspects of this field has been the link between CHIP and inflammation. And this was actually apparent in the very first data set that we looked at, the first 17,000 individuals that we examined, because we noted that individuals with CHIP had increased mortality compared to people without CHIP, and that couldn't be explained by leukemia, which is still a rare disease and couldn't shift overall mortality by that kind of margin. And we recognized that in this paper and that there was an association with cardiovascular disease, that both ischemic coronary heart disease and stroke had a increased risk, increased probability with a significant hazard ratio over 2 in individuals with CHIP, even correcting for all the known cardiovascular risk factors. So this is always a risk in those first types of studies where you didn't have we didn't set out to see this association. We were exploring the data and found this association with cardiovascular disease. We went back and looked at 4 independent cohorts. These are prospective studies where there's blood drawn at the beginning of the study. We assess whether they have CHIP. They're followed from the subsequent years, and we see whether they go on to develop a cardiovascular event. And in all 4 cohorts, recapitulated the initial finding that that having CHIP at the beginning of the study increased the risk. This was even true in 2 cohorts we looked at with early onset cardiovascular disease, where quite a few of the individuals had JAK2 mutations, and when there were tiny clones, but then went on to get cardiovascular disease later. So those genetic associations don't mean there's any causal association or causality between a mutation in the blood and the outcome of cardiovascular disease. The model system that we used and that is commonly used in this field is a murine model where we can change the genotype of the blood, leaving the rest of the mouse the same. So can a mutation just in blood cells alter the risk of cardiovascular disease? And of course, as hematologists, we always think about the fact that blood cells can influence any organ because those stem cells are going to give rise to neutrophils and monocytes, macrophages, platelets, and red blood cells that have the capacity to influence the function of all organs. And so mice don't get cardiovascular disease during the lifespan of a postdoc, but they do get cardiovascular disease if you treat the mice with a high cholesterol, high fat diet, particularly if you knock out the LDL receptor. They get extremely high cholesterol levels, and in a matter of weeks to a few months, develop atherosclerosis. So we transplanted mice with either wild type cells or TET2 knockout cells. We'd already noted that TET2 mutant cells were particularly associated with cardiovascular disease, and the mouse models of TET2 knockout recapitulate human biology very well. We we introduced those into the bone marrow of a LDL receptor knockout mouse, fed the mice a high-fat diet, and those mice get accelerated atherosclerosis. The heterozygous knocked out mice for TET2 get larger cardiovascular, larger atherosclerotic lesions. This is a descending aorta with an oil red O stain, and the homozygous get really quite dramatically accelerated atherosclerosis in the mouse. And this has been a super robust model. Many labs have recapitulated this over the years. What could be driving this? In a variety of model systems, whether it's cholesterol as a stimulus or other inflammatory stimuli, TET2 mutant cells elaborate more inflammatory cytokines in response to an inflammatory stimulus. This was a model of gout that we were looking at, where we can expose macrophages to monosodium urate crystals, and they get activation of the inflammasome. They get a greater inflammatory output if the TET2 cells are mutated, the TET2 macrophages are mutated versus wild type. And in many of these studies, the cytokine that comes out on top is IL-1 beta, but also consistently CCL5 and a number of other inflammatory cytokines. That link to IL-1 beta for TET2 mutations was also true in human cohorts. This is another cohort from the NIH thank you, that was 100,000 whole genome sequences. If you look at the genes that are mutated, it's exactly the same we've seen in every other cohort, DNMT3A, TET2, ASXL1 on top. The age association is true in every single cohort, same curve. And but in this data set, they had measured inflammatory cytokine levels in the serum for these different cases, so we could look at which mutations are associated with which cytokines. And you may be able to see, I have a cursor, which I don't. Nope. So if you look at the second row in panel C, there's a bright red dot rectangle above TET2. So IL-1 beta expression is very high, specifically in individuals with TET2 mutant clones, which is consistent with what we see in the mouse. And I didn't put it in here, but that also ended up lining up for the cardiologists here with findings from a study called the CANTO study, which was a 10,000 person randomized controlled clinical trial of canakinumab, an IL-1 beta blocking antibody for the treatment of cardiovascular disease, since IL-1 beta had been implicated in inflammation and cardiovascular lesions. It met its endpoint. There was decreased major cardiovascular events and actually decreased mortality. And so they went back after seeing our studies, sequenced about 3,000 of those individuals, and found that the individuals with no CHIP had almost no benefit from canakinumab. The individuals with TET2 mutations had a very substantial benefit from canakinumab, the IL-1 beta blocking antibody, and those with CHIP without a TET2 mutation had almost no effect. So TET2 really was a predictor of the response there. That drug didn't move forward for business reasons. They have another indication for that drug, but there are other drugs either targeting NLRP3 or IL-1 beta that are in development, and this could be used as a biomarker of response. So this field now has marched through many different diseases through a variety of approaches. Some are large cohort studies, like I've described. You look at a large number of individuals who have CHIP compared to not, look at their outcomes and see what the associations are. There are epidemiology studies like I'll describe next, and then the functional studies as I've described. So I'll show one example actually of each type of approach. This is liver disease, where we've used huge cohort studies and then murine models to study it. So non-alcoholic fatty liver hepatic steatosis, very common in our society. Non-alcoholic steatohepatitis, or NASH, is when the liver cells become inflamed. Fibrosis can result from that, and ultimately cirrhosis. We looked at chronic liver disease, which is mainly a combination of NASH and cirrhosis, and found that in multiple cohort studies, the Framingham Heart Study, the Eric study, the UK Biobank study, and UK Biobank SNP arrays, that in each of these studies, and then as a fixed effect model kind of meta-analysis of them, that there was about a twofold increased risk of chronic liver disease in individuals with CHIP compared to individuals without CHIP. And when we looked either by imaging or by diagnoses at fatty liver, there was no association whatsoever, but there was a strong association with NASH and the development of inflammation. There was liver MRIs in a cohort of this study. And if you see it on the upper right, you can see that there is the cumulative incidence for individuals with CHIP is really quite substantial compared to individuals without CHIP. When we did this, and now when we've done it in really any of the associations with CHIP, almost all of the risk can be attributed to individuals with large clones with a variant allele fraction of 10%. And you can imagine that just the number of inflammatory cells, number of mutant myeloid cells, is going to be linked to the risk of these inflammatory outcomes. And so you see a nice association with the variant allele fraction of greater than 10%. The numbers get smaller because many of the patients don't have a large clone. And in those individuals with smaller clones, the association is much weaker. The other thing that we find is that there's a huge genotype dependent association with these various outcomes. DNMT3A mutations tend to be very benign, not have much of an effect. TET2 mutations have one of the strongest associations with certain inflammatory outcomes, and JAK2 mutations can also be unique. And in this particular case, JAK2 mutations are extremely powerful in risk of chronic liver disease. So then we went on again to try to understand causality of a mutation causing a phenotype. And in this case, again, used a high-fat diet, the liver cells can become inflamed and ultimately develop cirrhosis, or at least have reticulin staining after long-term treatment. And you can see on the upper left, mice with wild-type blood cells fed a high-fat diet did not develop significant cirrhosis. But in the upper right, you can see that mice with TET2 mutant hematopoietic cells do develop cirrhosis, seen by the red reticulin staining. If you treat, knowing that there is activation of the inflammasome and IL-1 beta, if you treat with an NLRP3 inhibitor in the chow along with the high-fat diet, you can mitigate that development of fibrosis significantly and statistically significantly decrease fibrosis. So there are NLRP3 inhibitors that are in clinical trials now, and one question is whether CHIP or TET2 mutations would be a good biomarker of response in various inflammatory situations. So very distinct outcome is thrombosis. We wondered whether inflammation could lead to thrombosis or there'd be other genotype specificities. We looked at 500,000 cases in the UK Biobank again, and in this had a very different distribution where TET2 mutant CHIP had minimal or no effect on thrombosis. ASXL1 had minimal or no effect, but JAK2 had a strong effect with a 4-fold increased risk of thrombosis. And we took a lot of care to make sure that these are individuals who did not have a myeloproliferative neoplasm. They had normal blood counts, and even excluding people who had slightly elevated blood counts that were still in the normal range, you still see this impact of JAK2 mutations on thrombosis. That said, that's very rare. So it's not necessarily the first thing to work up when somebody has a spontaneous thrombosis without other risk factors. It's probably more rare, significantly more rare than things like factor V Leiden, but can be a cause in individuals. And these individuals were also enriched, just like in myeloproliferative neoplasms, with unusual thromboses like hepatic vein thrombosis. So it makes sense to check JAK2 mutations in individuals with unusual thromboses, but a very different genotype spectrum. So I mentioned an epidemiology approach. A wonderful postdoc in the lab, Lachelle Weeks, took this approach as she learned to become an epidemiologist. And so she argued that if patients with myeloid malignancies will have a precursor state prior to their diagnosis, so they'll have CHIP for a certain number of years prior to their diagnosis of myeloid malignancy, that they might have new diagnoses of various conditions in the years preceding the diagnosis of a myeloid malignancy. We also know that patients with myeloid malignancies also develop cardiovascular disease and other inflammatory diseases, but they have major competing risks of their myeloid malignancy. So what conditions are diagnosed prior to the diagnosis of myeloid malignancy at the state when somebody might have CHIP? And to do this, she used the SEER database, which is our database of all cancers in the United States. They can be linked in individuals older than 65 to Medicare data, so we know all of their other diagnoses and medications. And what she found actually mapped extremely well to the cohort studies we described, where we have mutations at the start, CHIP mutations, and we look for outcomes. She found an elevated risk of cardiovascular disease, of pulmonary disease, metabolic disease, including diabetes, bone and joint disease, and a decreased risk of neurodegenerative disease, including Alzheimer's disease. And the decreased risk is, fairly substantial for that disease. She then dove into the individual risks, ischemic heart failure, atherosclerosis, COPD, kidney disease, fatty liver disease, osteoarthritis, osteoporosis, RA, and gout. And amazingly, even the effect size, these odds ratios line up really well with the hazard ratios that we see in cohort studies. So these really large cohorts with many, many thousands, tens of thousands, or hundreds of thousands of individuals end up being very reproducible, no matter which way you look at it. So as a summary of some of the diseases that have been shown with both mouse models and human genetics to be associated with CHIP, we see these cardiovascular diseases, liver disease, kidney disease, et cetera. And again, Alzheimer's disease, either in specific Alzheimer's cohorts or in these large unbiased cohort studies, have less Alzheimer's disease. We don't know the biology there, though we know that many of the cells in the brain, the tissue-resident macrophages, potential microglial cells, bear these mutations. Again, the TET2 mutations seem to be particularly active. Those cells are hyperphagocytic and they're inflammatory. They may be operating a little bit differently, and exactly how they influence the risk of neurodegenerative diseases under active investigation, particularly in SIDJ as well as lab. So the area that ends up being studied most in a cancer center is CHIP following chemotherapy, because we're the administrators of chemotherapy. We're the doctors who look after the cancer survivors, who often have these clones in their blood following successful treatment of a solid tumor. When we've looked at individuals who get therapy-related MDS, this is a study by Coleman Lindsley when he was in the lab. We were able to look at, this is looking at patients in the National Biobank for patients who underwent allogeneic stem cell transplant. We looked at the genetics of people who went through stem cell transplant for various indications. And in therapy-related myeloid malignancies, P53 mutations and PPM1D, which again is a phosphatase that regulates P53, are the most enriched in therapy-related malignancy, myeloid malignancy, compared to non-therapy related or primary MDS. And this is part of a real revolution in how we think about therapy-related malignancies. Again, it's one of the, most heartbreaking outcomes in patients who have a solid tumor, get successfully treated in full remission, and then go on to get a therapy-related MDS or AML, which tends to be among the most difficult types of MDS and AML to treat. We now think about it rather than the cells being mutated directly by the chemotherapy and radiation, and that being the initiating event. Instead, we often think about it now that those P53 mutant clones were already present in the bone marrow of an individual. They got exposed to the chemotherapy and radiation. That clone got bigger. That expanded clone doesn't immediately drive a malignancy, but it creates a larger number of cells at risk of acquiring the additional mutations that will cause it to progress to a full-blown malignancy, which in the case of P53 mutations is very difficult to treat. Another example of this is a study we did in lymphoma patients who have received chemotherapy for their lymphoma and then are going on to get an autologous stem cell transplant. And those samples prior to transplant are systematically banked and gave us a nice group to study. So these are patients who got treated for non-Hodgkin's lymphoma with chemotherapy. And you can see the prevalence of CHIP is way higher than we see in the general population. Even in individuals in their 30s have 10% have CHIP. Those in their 40s have 30% and even higher in older individuals. So we see that universally, that those individuals who are exposed to chemotherapy have much higher rates of CHIP and a much higher rate of P53 mutations. If you look at these mutations that we find, PPM1D is particularly powerfully selected for, is probably the most powerfully selected for mutation in the genome in individuals who are exposed to chemotherapy. And P53 mutations are much more common in individuals who had chemotherapy than individuals without chemotherapy. But importantly, if an individual has CHIP prior to their stem cell transplant, their autologous stem cell transplant, the risk of getting a therapy-related malignancy is markedly increased. And when they do develop a therapy-related malignancy, it's from the clone generally that was present in the transplant. Similarly, individuals with CHIP prior to their transplant had a very significantly worse overall survival. Some of that was due to increased risk of heart attack, but certainly much of it due to therapy-related malignancy as well. But major effect in long-term outcome. This has actually been borne out in interesting ways. I didn't put this slide in either in the setting of allogeneic stem cell transplant, this being one of the biggest and greatest centers for allotransplant in the United States. Having in individuals who go on to get a donor-derived leukemia and an allotransplant generally have received the initial mutation in the form of CHIP in the transplant product. That's led to a big debate in the transplant field of whether every donor should be screened or not, and that there are pros and cons to that. Another incredibly interesting finding from those studies is that if there's a DNMT3A mutation in the product, in the allogeneic donor, there is more graft-versus-host disease and less relapse. DNMT3A mutations are actually very powerful drivers of phenotype in T cells and have an anti-exhaustion phenotype. And so you can imagine that those DNMT3A mutant cells may have better graft versus leukemia effect, as well as more graft versus host effect. There's even been questions about whether a DNMT3A or TET2 mutation could be introduced into a CAR T cell. The FDA has said, I think Carl June had asked that question. The FDA said that was not a good idea to introduce a tumor suppressor into a cellular therapy product, but it does very robustly have an impact on T cell function. So clinically, a critical question then is whether the presence of CHIP causes a dramatic, what is the risk for those individuals? And that is really the central question for all pre-malignant states. If we're going to think about intervening on anybody, we have to intervene on the patients who have significant risk and not induce toxicity in a population of individuals who have very low risk. And so really defining who's at greatest risk is a high priority. And this also was led by Lachelle Weeks. And over the years, we and others had recognized a number of risk factors, but not put them all together. Some mutations clearly are associated with a higher risk of getting cancer. Some are associated with multiple mutations. More mutations is associated with higher risk. The bigger the clone, bigger the risk. And red cell size, going back to Clement Finch, the RDW was one of the most powerful from our very first studies all the way through. RDW is one of the most powerful predictors of outcome. And that actually links to a very old literature going back to the 50s and 60s of RDW being a powerful predictor of cardiovascular disease and overall mortality. So we did this again in the UK Biobank. So we had 500,000 individuals. We could do a derivation validation cohort with very significant numbers, identify the individuals with mutations, and build this model just on the risk of getting a blood cancer, just on the risk of myeloid malignancies. So the genotype specificity varies by orders of magnitude. DNMT3A mutations are by far the most benign of the mutations. They have very low progression to myeloid malignancies. Splicing factor mutations like SRSF2, SF3B1 are associated with a very high risk. Mutations that we really associate with AML more than MDS, like RUNX1 and IDH mutations, are associated with an extremely high risk. JAK2 mutations are associated with an extremely high risk, and others are more intermediate. PPM1D mutations seem to be a very powerful marker of having been exposed to chemotherapy or radiation, but a very weak driver of progression. So that has often led to the question, are DNMT3A mutations actually protective? They're not protective. They still, in the green line here, are associated with an increased risk, but the absolute risk remains very low compared to all other mutations put together. So one question when building these types of models is always, do you build a really complicated one like polygenic risk scores where there are thousands of inputs and it spits out a prediction, or do you do something simple like we've often had in cancer with things that we know about, but it's an oversimplification? I've tended to like the simple ones because they perform quite well and everybody knows what is going into the model and why it's working. But if you just score this very simply based on high-risk mutation being present or absent, being really powerful effect, the number of mutations, VAF, the variant allele fraction, the RDW, the MCV, cytopenias, yes or no, and age, you get a very powerful predictor. With the two most powerful, we did a recursive partitioning model. The two that come out as the most important features, first is high risk versus not, and the second being RDW, being the more powerful than having multiple mutations or anything else. So really, really striking. And that enables us to have just, again, trying to stick with a simple model, low, intermediate, and high risk. The good news is that about 90% of the individuals have low risk CHIP and extremely low absolute risk of progression. And we now have a CHIP clinic that Lachelle Weeks runs. We get lots of referrals from doctors who say, this patient has this mutation in their blood. What do I do about it? A general practitioner, a primary care doctor will be flummoxed by that sometimes. But we can say that those low risk patients, which is the vast majority, don't need to be seen, don't need to be followed closely. And that's a relief because the number of those individuals is enormous and would swamp hematologists. Intermediate risk is a bit more common, about 10%, but has a 35-fold increased risk of developing a myeloid malignancy. And then high risk, with about 1%, has a 350-fold increased risk, and more than half of those will develop a myeloid malignancy in the next 10 years. So that is the truly high-risk group. We do see those patients with some frequency in our clinics, and there are already a set of clinical trials underway in those individuals to see if the clones can be decreased in size and the risk of progression can be decreased significantly. While we built the model not on survival, but on risk of malignancy, this performs quite well for risk of overall survival. It's a relatively young and healthy cohort. The individuals who go into the UK Biobank tend to have relatively few comorbidities and are in their 40s and 50s. And so 10-year survival is quite good. Low risk chip barely moves that. Intermediate risk does a little bit, but the high risk chip had only a 50% 10-year survival in individuals who started at a young age. And so those high-risk mutations, those high-risk state create a quite dramatically increased overall mortality and a marker for a range of bad outcomes. And that's been validated in many cohorts. The first one that it was validated in was a cohort that is much older and much more comorbidities. A lot of cardiovascular disease is a cohort to study cardiovascular disease in the ERIC cohort. And the features still predicted development of hematologic malignancy and overall survival. And if you dive down into the individual causes of mortality, the biggest absolute cause of mortality in those with high-risk CHIP is, again, cardiovascular disease. The relative risk is very high for malignant myeloid diseases, blood cancers, which makes sense, and then increased risk of other effects as well, and even a hint of the decreased neurologic outcomes as well, and eager to really understand that biology. So that was what I was going to talk about today. That CHIP is extremely common, as are pre-malignant states for all cancers. That in this case, it influences a variety of outcomes because the mutant blood cells are capable of causing inflammation in a variety of tissues, including cardiovascular disease and other inflammatory diseases. They elaborate higher levels of inflammatory cytokines, many of which can be reversed by NLRP3 inhibition. That CHIP clones expand under selective pressure, and when we create model systems, we need to recapitulate that selective pressure to understand whether the clones grow out. And the risk of progression to malignancy in individual CHIP depends on what genes are mutated, what the blood count parameters are, and can be predicted with this clonal hematopoiesis risk score. And just to say that I've been so fortunate to work with so many amazing trainees, almost all of whom have led this work have been physician scientists. Sid Jaiswal, Lachelle Coleman, Susanna Adams Sperling, and Peter Miller, all running their own labs, and are physician scientists themselves. And I'd be happy to take any questions.
So I have a couple of questions, and I'll pose the first one. The inflammation involved with clonal hematopoiesis is NLRP3 dependent and activation of the inflammasome, but why? I mean, what's the mechanism for that?
So we've got a bunch of work going on, and haven't put it all together, but in slides yet. But they in the biology is likely going to be a little different for different mutations. But in the case of TET2, which is particularly inflammatory, we see that one of the primary proteins that TET2 interacts with is a protein called OGT, which glycoalkylates proteins. It's a central metabolic sensor for cells, sensing nutrients. When TET2 is mutated, glycoalkylation is altered, and there's massive lipid overload in cells, and they start to accumulate lipid droplets in the cell, and those lipid droplets are inflammatory, and they end up activating the inflammasome. that is something that can be modified. If you lower the cholesterol, lower the nutrient exposure, then those cells become less inflammatory. And that's really consistent with our models where TET2 is not so inflammatory without a high cholesterol level or without a high glucose load, and is very inflammatory in their presence. JAK2 is downstream of just about every inflammatory cytokine, so probably is influenced by that. What the biology of some of the other ones, like splicing factor mutations and ASXL1, are much more poorly understood in general, and so we don't have as good model systems to study them, which makes it a challenge. So.
And I guess the second question is, you did talk a bit about this, but in high-risk individuals with clonal hematopoiesis, what would be the strategies that that could be employed to decrease that the clone?
Yeah,
I think conventional chemotherapy wouldn't be a good idea.
Probably not a good idea. So there are clinical trials of decitabine, so a drug that has efficacy in MDS. Could that decrease the size of the clone and just decrease the risk of progression because there's fewer cells to acquire other mutations? There are a variety of inflammatory pathway inhibitors that are being used. In clinical practice, there's also just maximal medical management of the cardiovascular risks and lowering cholesterol and stuff. But those are the types. There are particular mutations that have great drugs, one of which is IDH. So there's a national clinical trial for individuals with IDH mutant clonal hematopoiesis, and those can be targeted really well in leukemia and likely targeted really well at that early stage. That's closer to the model of CML, chronic myelogenous leukemia, which is pretty close to CHIP. It's a single mutation, leads to altered blood counts, but with a high risk of progression. And we have a great drug against it. And if you use it when there's only a single mutation, there aren't additional mutations, a drug works extremely well. So IDH hopefully is like that, and it is a high risk mutation. There are huge efforts underway to get mutant selective JAK2 inhibitors. When those come out, I'm sure that people will want to try it in this state. So if we have a drug for an individual lesion, we'll try it. Other than that, it'll probably be things like that have efficacy in MDS and that could be moved earlier. That's the playbook in other blood cancers. So in MGUS and smoldering myeloma, precursors to multiple myeloma, there's a huge amount of clinical activity because we have like 20 drugs now that have great clinical efficacy in multiple myeloma. Can we start to use those before somebody has organ dysfunction and before somebody has bone lesions and really decrease the risk of progression to myeloma at all? So if we have good drugs, moving them earlier is a great option. So
thanks.
Oh, sorry. Yeah. So the others. Yeah. Sorry.
That was a really great talk. I'm a molecular pathologist and do NGS genetic testing day in, day out. So we deal with CHIP and how to report it to patients. So my question to you is, do you have recommendations on like a variant allele fraction threshold, certain genes, et cetera? Because most of the time when we detect CHIP, it's not the clinical indication. It's an incidental finding.
Yes.
And you and the people in this room that you've now educated and probably are already steeped in this understand this biology really well, but the vast majority of clinicians have no idea what to do with it. So there's this risk that it'll just cause confusion. So that's what we deal with. What are your recommendations on clinical reporting?
That's a great question. So the question is, what do you do about clinical reporting when you find a CHIP mutation in a next generation sequencing assay that was sent for other reasons? And that is what fills our CHIP clinic, because we don't recommend anybody get tested for it because we don't have interventions that are proven yet. But that happens all the time. And the biggest thing is to not cause psychological harm by telling people that they have a, pre-leukemia state if their risk is low. So that was one of the motivations for defining the state, and the WHO and the International Consensus Conference, the ICC, adopted those definitions of CHIP and CCUS. So at least that there's a diagnostic code that you can say and has criteria for whether or not it's CHIP. And then our hope for the CHRS, the clonal hematopoiesis risk score, is to be able to even say, based on data that you would already have, just the CBC and the sequencing, this is low risk, but the clone is present. And then at least in terms of reporting, you've done your job of reporting the clone and the risk, and then can leave it to the hematologist or the physician to decide on what kind of follow-up might be needed. But yes, a lot of it is reassurance at this stage. We don't think you can not report it, but and this comes up in all kinds of circumstances. Comes up in all of the assays that are being developed for blood biopsies for detection of cancer. These mutations are present in massive quantities compared to the things that they're being looked at. It comes up with confounding germline diagnoses, Lee-Fraumeni versus a P53 large clone can look really similar, and sometimes need to go to fibroblast sequencing and stuff.
That's great. I'd push back a little bit on the comment you made. I don't think you can not report it, right? Because we'd have to think about, what are the potential harms of reporting versus not reporting, right? I mean, you've just outlined so much great data about the high risk versus low risk, et cetera.
Yeah.
Not saying we should or shouldn't, just is something that probably requires some thought.
Yeah, I guess, one thing that is not reported often is like if you see a DNMT3 or TET2 clone in a solid tumor, that's often not reported. That said, there was a recent New England Journal paper a few weeks ago from Charlie Swanton's group showing that if you have CHIP in the tumor, it's in lung cancer, it's associated with a much worse prognosis. So it's not irrelevant to the biology of solid tumors either. So I think at our institution, they are still reported, but not sort of highlighted.
Great work. Thanks.
That was a great talk. Thank you. So sequence alterations are like easy to identify and we have the most data out there, but do you think that's the tip of the iceberg? Are there structural variants, amplifications, deletions, or epigenetic alterations that may be doing the same thing?
Definitely, and that's a great question. So at least the amplifications and deletions we can detect because all of these cohorts have SNP arrays for them as well. And so we can detect these both lymphoid and myeloid copy number abnormalities, and they work just the same. Some of them are very powerful. They're more on the lymphoid side. A lot of those are pre-CLL states. We've wondered about, but the population-wide prevalence of fusion proteins, it would be fascinating to understand. We don't have that data, and not trivial to acquire that type of data for a wide number of possible fusions across hundreds of thousands of individuals, but it would be really fascinating to know. And then the epigenetic state as well is, I'm sure, relevant. I'm sure that is incredibly important. And that may be what we see when we see these expanded clones with no drivers. They may be epigenetically optimized cells in some way that have a better fitness than other hematopoietic stem cells, but don't have an easy way to analyze that epigenetic state of all of those clones. But I'm sure that's true.
Have you followed the clones longitudinally, so for the same patient, and do they ever regress or decrease in size?
Great question. So the question is, if you look longitudinally at individuals, do clones sometimes get smaller? Do they sometimes get smaller or bigger? There are cohorts that have that. George Vasiliou has done a large analysis of those, and there's been a variety of technologies used or computational approaches to predict trajectory. The smallest clones have the most variability. The biggest ones tend to almost never go away, but they sometimes go up or down. It's hard to know sometimes whether that's due to changes in blood counts because the clone might be present more in one lineage than another. And it correlates extremely well with those high risk versus low risk mutations. So DNMT3 is a really weak driver, can go up and down. P53 mutations may go up when somebody's exposed to chemotherapy and then drift down a little bit until a malignancy might develop. So that the competitive advantage under a normal steady state may be very weak. And then those drivers like JAK2 or splicing factor mutations have a much steeper trajectory on average than other mutations. So the risk of malignancy and the clonal trajectory align very well. So that's a great question.
Thank you for, oh,
Yeah. 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 It's true that some of the chemotherapy agents actually have almost no selective pressure on the p53 mutations, which is fascinating. And then some, like platinum agents, are incredibly powerful selective pressures, and radiation might be one of the best. And so that is true. I think there's so much fear of taking an established, regimen and altering it on the base of this without understanding whether that would create any more risk. But people talk about it all the time, and I think some people actually do it off themselves without data. But it is something that we've wanted to sort of figure out how to define better so that people could take that into account and assess risk. But you're right, it'd be those types of situation with low risk for recurrence in breast cancer, and the relative benefit of the chemotherapy is pretty modest, and then you might start to get into the range where the risk and the benefits start to collide a little bit.
Thanks all for coming today. Dr. Ebert is on a tight schedule here, but we really appreciate the turnout. We had over 135 people on the Zoom, so I think that could fill the entire auditorium. So encouraging everyone to come in person, for the ones coming on. And thanks so much again for a great talk, Dr. Ebert.
Thank you.